Welcome to this explainer. Today, we're diving into something that sounds highly technical on the surface, but it actually affects every single one of us. If you've ever interacted with the healthcare system, your health data was translated into a universal language of codes. But honestly, that language was due for a massive overhaul. So we're unpacking the 11th iteration of the International Classification of Diseases, or ICD-11, which was released by the World Health Organization on June 19, 2022. We are going to explore how this system went from being a huge kind of static list into a truly thrilling, modern, cloud-ready digital architecture.
Here's our roadmap for today. First, a global health vocabulary. Second, the digital architecture leap. Third, deconstructing STEM codes. Fourth, the power of extensions. Fifth, new coding conventions. And finally, the road to implementation.
All right, starting with Section 1, a global health vocabulary and how it's uniting 90 countries. The World Health Organization, working alongside groups from over 90 different countries, undertook this incredible macro-level ambition to unify the entire world under a single medical language. This was a truly global effort to capture injuries, diseases, syndromes, symptoms, morbidity, and mortality with an unprecedented degree of detail. The crucial takeaway here is that this isn't just about healthcare billing, right? It's about fundamentally measuring human well-being across borders and across languages. The WHO actually recognizes that a country's health statistics are the truest measure of its well-being. This common vocabulary is exactly what allows global health data to be analyzed together, seamlessly.
7.4 billion. Just let that number sink in for a second. To put the sheer scale of this into perspective, the system is designed to connect health data for 7.4 billion people globally, speaking 7,000 different languages. That is the staggering mandate of ICD-11. It provides a singular framework so that a hospital in Tokyo, a rural clinic in Nairobi, and a massive medical center in Chicago can all speak the exact same clinical language. Moving into Section 2, the digital architecture leap. Basically, upgrading the OS of global health.
To really grasp this major leap from analog lists to a modern digital architecture, you have to realize that the previous system, ICD-10, was more than 25 years old. It was first approved by the WHO all the way back in 1989. While the ICD has followed a set of structural rules for over 150 years to maintain its integrity, the actual technology of medicine has drastically outpaced the tools we use to categorize it. That makes this recent 2022 release of ICD-11 a desperately needed upgrade.
So what's under the hood? Well, this new framework acts like a true operating system upgrade. It's fully ready to integrate with artificial intelligence and cloud systems. Because it's fundamentally a digital architecture now, it allows for continuous updates and interoperative compatibility with other electronic terminologies. It heavily reduces the need for those constant post-production clinical modifications. Plus, it has the potential to actively support AI-assisted coding, which is a total game changer.
And by going digital, the system can capture incredible new specificities, including 7 entirely new chapters, bringing ICD-11 to 27 chapters in total. It finally addresses diagnoses that were not adequately captured before, like antimicrobial resistance, melanoma subtypes, and subdivisions for HIV. The new chapters are honestly fascinating. They address everything from diseases of the immune system to sleep-wake disorders in Chapter 7, and even traditional medicine conditions in Chapter 26.
Okay, Section 3, deconstructing STEM codes. Let's look at the actual mechanics of the system. Imagine trying to create millions of static codes for literally every possible medical scenario. Impossible, right? Instead, the WHO introduced this highly flexible framework built around 2 main components. Think of STEM codes as your foundational building block. They are capable of standing completely alone to represent a specific clinical condition when only one code is collected. By design, they ensure that the core information captured is immediately meaningful on its own. You can use them entirely by themselves, or you can use them in combination with our next concept, extension codes.
I absolutely love this part. There are these uniquely human quirks built right into the strict structural rules of the codes. For instance, the first character corresponds to the chapter, and the second character must be a letter just to differentiate it from ICD-10. But look at the rule for the third character. It requires a number simply to prevent the accidental creation of potentially offensive words. And of course, the letters O and I are entirely excluded from the whole system, so human coders don't confuse them with the numbers 0 and 1. So smart, right?
Which brings us to Section 4, the power of extensions and building clinical precision. If STEM codes are your foundation, think of extension codes like snapping specialized Lego bricks onto that foundation. These Type 1 codes are the real secret to incredible precision here.
They expand the system's flexibility far beyond what a STEM code can do alone. They exist purely to add granular specificity to a diagnosis. So, if your STEM code gives you the broad category of the disease or injury, the Type 1 extension code gives you the hyper-specific details of that exact medical event. But remember, they can never be listed entirely on their own. So say you need to specify the exact anatomy or maybe the specific substance involved in an injury, a Type 1 extension is exactly the tool for the job. They cover diagnosis timing indicators, severity scales, the level of consciousness of the patient, and specific histopathology, which is absolutely critical for cancer registry reporting, a massive upgrade in this new version.
On the flip side, we have Type 2 extensions. These provide vital context about the patient's actual journey rather than the disease itself. Assigning a Type 2 extension code doesn't change the core meaning of the underlying diagnosis code at all, but it dramatically alters how it's interpreted for the medical record. It gives healthcare providers and data analysts the real-world context of the medical encounter.
This type of coding is brilliant because it allows healthcare workers to precisely track when an adverse reaction happened. For example, XY6M tells us the condition was present on admission, but XY69 tells us it developed after admission while they were in the hospital stay. This kind of timing data is incredibly valuable for tracking things like hospital-acquired infections or surgical complications.
Okay, let's actually put this Lego analogy into practice. We are going to cluster a post-coordinated code, snapping together disc degeneration and specific spinal anatomy into one perfectly documented clinical concept. This is a huge difference from ICD-10. You just take the STEM code for the disease, add the extension code for the exact C5-C6 anatomy, and link them right up with an ampersand or a /. This flexible system completely eliminates the need for messy local customization, and it aligns beautifully with other systems like SNOMED CT.
All right, zooming back out for Section 5, New Coding Conventions. Basically, leaving the past behind. So out in the real world, the daily rules of medical coding have radically shifted. Beyond just STEM and extension codes, ICD-11 incorporates several major changes to long-standing coding conventions that coders have relied on for decades. For starters, say goodbye to Roman numerals. Arabic numerals are now used for chapter numbering. Categories now require a minimum of 4 characters and include 2 levels of subcategories. Plus, the relationships between diseases are explicitly linked now. If there's a causal relationship, the preferred term is due to. If 2 conditions simply occur together, the system uses the term associated with.
Just take the example of Huntington disease here. It really shocks you into realizing just how vastly the alphanumeric syntax has changed between the 2 systems, while the code structure remains alphanumeric, ranging from 1A00.00 all the way to ZZ9Z.ZZ. Seeing a simple G10 turn into 8A01.10 really drives home that this isn't just a minor update. It is a complete structural overhaul.
Finally, Section 6, the road to implementation. How do we actually update the United States?
The WHO has released ICD-11 globally, sure, but plugging this into the massive complex machine of the US healthcare system, that is a whole different ballgame. The syntax changes mean that entirely new decision support tables and massive retraining efforts are required before a single medical claim can be adjudicated. We are talking about fundamentally restructuring the huge databases that house these codes and completely overhauling the intricate edits within claims adjudication systems. Literally every coder, every piece of billing software, and every insurance company has to be updated.
To really grasp the gravity of this task, we just have to look at history. The previous system took up to a dozen years to fully roll out in the US. It took 9 years just to implement it for mortality reporting alone, and 12 years for the clinical modification and procedural coding systems to be released. It's a monumental undertaking.
Right now, as the Department of Health and Human Services evaluates the pathways toward adoption, an official release date in the U.S. hasn't even been cited yet. They're still actively researching the costs, figuring out how to use it for quality measures, and seeing if it supports real-world evidence for device surveillance. So we're left with a pretty massive question. With the rapid advancement of medicine and AI, is our infrastructure truly prepared for this incredible digital leap?